I'm Kjell Arne Johansson. I'm a professor at the Bergen Center for Ethics and Priority Setting in Health, BCEPS. I'm also a medical doctor working at Haukeland University Hospital. I will now give you a mini lecture, an introduction to priority setting in health. Every country faces the health gap. The population have higher expectations and needs than financial resources available. That leaves population to set priorities. And the most common priority setting mechanism is implicit rationing, and explicit rationing is much harder, but it is important to aim for more transparency in priority setting. The simplest definition of priority setting in health is to rank order patients or health services in order of importance. And here you see an example of how Ethiopia rank order interventions according to a mix between cost effectiveness, priority to worst off, and financial risk protection. And after a long, thorough, in-depth process, they launched this report in 2019, and you can see that antihypertensives and statins were given high priority compared to prostate cancer was given low priority. Interestingly, management of childhood cancers was given medium priority, and then that, as a consequence, will be provided with some user fee. The question is this rank ordering fair or not? That leaves us to look more into universal health coverage. And that leads us to the cube. There are 3 dimensions countries need to think about at all levels when you set priorities. The first decision that needs to be made is what services should be given high priority. And we saw from Ethiopia that antihypertensives were included, but management of prostate cancer was not included. If all services are included, that means you have filled the whole what services access. The second thing that needs to be deliberated on and decided on is the priority of what patient groups would you want to prioritize. What's the inclusion eligibility criteria? Do you want it to provide the service to everyone who has a potential benefit from the treatment, or do you want to narrow it? Do you want to give higher priority to younger groups compared to older, for example? The third dimension is to reduce the financial risk. And then with universal public finance providing all services free of charge, then you would have a full blue universal health coverage cube. But maybe this is not feasible and priorities are important. There are 3 steps to think about on the path to UHC, and this is highlighted in detail in the 2014 WHO report, Making Fair Choices on the Path to Universal Health Coverage. The first thing countries need to think about and do when they define an essential healthcare package towards UHC is to categorize and prioritize services. Criteria for priority setting and methods like cost effectiveness analysis, distributive cost effectiveness analysis are important. And then it's important that high priority services are given high priority. Start scaling up high priority services without financial risk before scaling up low priority services. And ensure that disadvantaged groups are not left behind. And there are examples of unacceptable trade-offs. Here is one. It would be considered unacceptable to expand coverage for example, coronary bypass surgery before securing universal coverage for skilled birth attendants and services for easily preventable or easily treatable childhood diseases. And here are 3 categories of ethical considerations you need to think about. Choose key services fairly. Does that mean you prioritize according to cost effectiveness, priority to worst off, or financial risk protection, or a trade-off between the 3? Second, high priority groups first, and define who the high priority groups are. Is it the sickest, the poorest, most marginalized? Do you want to give high priority to special working groups because they have an indirect importance, like health workers, teachers? And financial risk protection, think about going beyond reducing the user fees for special groups, but think about universal financial risk protection.